Hey guys, welcome back. This is another episode of Urgent Care Stories. We're going to get back to our regular episodes now. Today's episode, we're going to do it on a guy that I saw a few years ago. And it's an interesting case because when you take a brief history, you think one diagnosis, and when you get a more thorough history, you get to his true diagnosis. So, he is a 57-year-old gentleman, pretty well off, a little bit of high blood pressure, but not a ton of significant chronic medical problems. He's not on any blood thinners or anything. He is a pastor. He comes in and he is complaining of a 2-day history of nausea, vomiting, and headache. He says that about 2 days ago, he was at his church and he grabbed some food out of the fridge, started eating it, and then within about maybe 30 minutes or so, he started to have headache, nausea, and vomiting. When somebody comes in complaining of nausea, vomiting, and headache, there are two routes you can think. You can either think the nausea and vomiting is related to some sort of gastroenteritis or some sort of stomach bug that is causing the symptoms. Eating food, having nausea, vomiting, and stuff within 30 minutes, it's usually kind of some sort of food poisoning or gastroenteritis. Headaches, you would think because of the pressure of vomiting, because of dehydration, just because of the acute illness, you can have a headache. That's one approach you can think about it. The other approach is, could this be a intraparenchymal or a subdural hematoma, or some sort of brain bleed? So the textbook definition or the kind of presentation of a subarachnoid hemorrhage, which is a bleed within the tissue of the brain itself, is what we call a thunderclap headache. So out of nowhere, they get a smacking, terrible headache, worst headache of their life, associated nausea and vomiting, maybe some visual changes, maybe some motor changes or neurological changes, but it is headache, the worst you've ever had in your life, and it's acute onset. This guy came in and he was totally with it. He was sitting there, he was comfortable. You know, I asked him how bad the headache was. He said it was like maybe a 3, maybe a 4. It was enough to make him a little uncomforting, but not terrible. He's not over the table vomiting profusely. He's just sitting there tolerating everything pretty well. So, what's my approach for this guy? Well, I ask, hey, any history of brain bleeds in the past? Any history of strokes? Have you ever had an aneurysm? Anything like that? And he says, well, actually, I did have a brain bleed a few years ago. And I said, really? Okay, all right. So I think about, does this feel like a thunderclap? Does this feel like a horrible onset headache? He says, not really. I say, have you been taking your blood pressure meds every day? He says, yeah. I say, okay, well, let's feel your belly. Let's do a little blood work and let's kind of see where we're at from there. At this point, I'm thinking it's probably gastroenteritis because the food he ate was a little questionable, I think. It was a couple days old and the timing certainly fit a gastroenteritis, but I still have, he's bled into his brain in the past on my differential, and I'm thinking about that. So I do a blood count, a complete blood count, CBC, and a basic metabolic panel. I just want to check his electrolyte status. I want to check what his BUN and creatinine are to see if he's acutely dehydrated. That could maybe explain the headache. And I want to make sure he doesn't have an elevated white count, like a leukocytosis, that could explain maybe some sort of an infectious etiology in the abdomen. I push on his belly. He has no tenderness anywhere. The belly's pretty stable, so it looks okay. We get the blood work back. Everything looks normal. So a lot of times with gastroenteritis, all of your blood work looks normal. They're totally fine. So I said, look, given your history, I think it's worth getting a head CT. I don't think I'd feel comfortable letting you leave without scanning your head. And he says, yep, I think that sounds great. I appreciate you doing the CT for me. We send him over, we get a CAT scan. I'm waiting for the radiologist to read it. I start looking through the imaging myself. I'm not a radiologist, but I can pick up things here and there. And so when I see something, I see bright white spotting in the right occipital lobe of his brain. And I say, oh shit, that's a brain bleed. I say, that's an acute subarachnoid or intraparenchymal bleed. So I call the radiologist. I say, hey, is this his old bleed because he had a bleed a few years ago, or does this look acute to you? And he says, nope, that looks acute. I think you're on the right track. So I say, listen, man, you have another brain bleed. We got to get you over to the emergency department. We have to have a neurosurgeon evaluate, decide what they want to do for you. A lot of times with those types of bleeds where it's not causing a significant amount of neurological defects or visual changes, and it's just kind of a spontaneous bleed, a lot of times what they're going to do is control the blood pressure and then give them anti-seizure medications for a period of time, just because that blood, as it mixes with the tissue of the brain, sometimes it can increase inflammation and cause an excitatory response, which can lead to seizures. So that's what they ended up doing with this gentleman in this case. He did totally fine afterwards, didn't need any surgery, but this guy was just genetically, he had, you know, enough going on that he was just prone to these brain bleeds. So the lesson here is the history. You got to take a good, thorough history of these people. If you just said, oh, you ate something bad, oh, okay, yeah, well, how bad's the headache? Oh, it's not too bad. Yeah, just get out of here, take some Zofran, you'll be fine in a couple of days. You would have missed a brain bleed, and he could have later had a seizure and really could have had a catastrophic outcome for that. So anytime I think about ordering imaging, anytime I think, should I get a CT, should I not, and I'm on the fence, I'm almost always glad that I ordered the CT scan, because things like this pop up. You can get 100 normal scans, but eventually you're going to get one that has a brain bleed for that headache and that nausea and vomiting, and sure enough, this is it. The other thing that I learned is that not everybody's going to come in horribly uncomfortable, excruciating pain when they have a subarachnoid hemorrhage. This guy certainly didn't. He looked fine. So taking the history, listening to the patient, and making sure you get a good history is the important stuff here. That was today's episode. Pretty quick and easy for you guys. Hope you enjoyed that, and I'll catch you on the next one.